all of these are examples of how health workers can act against direct violence, but we can also act against structural violence. And many of you are involved with refugee clinics, clinics for people at risk for homelessness, Aboriginal health, prison health, and then with the environmental movement. And when we as health practitioners do this, we can be powerful voices. And so in terms of thinking about how we work, we talked a little bit about this yesterday. We can work at various parts of conflict, pre-conflict, during conflict, after conflict. We can do primary prevention, secondary prevention, tertiary prevention. And I don't think that it's worthwhile going over that in detail, but that's a health prevention model for those of you here who are health practitioners. So modifying the risk factors that lead to war, being primary prevention, or primordial prevention going even before that. So you could talk about primary prevention being weapon systems, primordial prevention being some of the root causes that they're going to talk about in session 1, secondary prevention, mitigating the effects of war, tertiary prevention when the horse is out of the barn, analogous to rehabilitation. And so this is a diagram from Joanna Santa Barbara talking about where we can act as health professionals in the cycle of violence. And again, we know that if we don't act, even after we've got peace agreements, we can start the cycle all over again. But we are able to act. Actually, when Joanna developed this, we both realized that this was analogous to some cycles of violence in terms of gender-based or domestic violence, too. That in terms of how that can go. And we've got organizations that can work at each level. And we think of human rights and environmental organizations. We think of organizations against weapon systems being primary prevention. Think about organizations during war, the secondary prevention organizations like Médecins Sans Frontières. The Red Cross operates at different levels. And then our group in Hamilton operates more on the tertiary prevention type of thing, post-conflict rebuilding. And I can talk a bit about that during the question period. We've got different ways that we can operate that I've talked a little bit about in terms of using our knowledge, skills, and values is how we've termed that in this model. There are other people who use analogies like head, the knowledge, heart, the values, and hands, the skills. So head, heart, and hands. So you can think of different ways that we have as health practitioners. So when we look at the ICRC and the MSF, they communicate knowledge from war zones. Sometimes they're the only organizations that can actually relate things. They can strengthen communities. Often the health sector is the only one that's left in a war zone and that functions. They can help the healing. When you go into a zone where nobody else is willing to go, you're extending solidarity to people, making them realize they aren't forgotten. You end up also saying that as a health practitioner of one side, even of the military, that people of the other side are valuable just as you are. So extending the concept of altruism, which other sectors may not do. We're able to personify the enemy. IPPNW was able to, you had American and Soviet physicians who were able to say, well, the physicians on the other side are people that we meet at conferences. Bernard Lown and Evgeny Chazov were both experts in sudden cardiac death. And they said, well, we've been to each other's houses, we're friends, so how can we blow up our friends? We're trying to save lives on the one hand, and meanwhile our countries are trying to blow up others. So that, again, is a mechanism by which we can work to act against war, and we can construct the superordinate goals, like in El Salvador. We can refuse to serve governments that do things that we consider unconscionable. People who've opposed the Gulf War or Vietnam War in the U.S. We can engage in diplomacy, like the people who in IPPNW who dealt with Gorbachev, but we also find that the International Campaign to Ban Landmines engaged in diplomacy at the highest levels. And we can redefine situations, so saying that situations aren't just political or military, they're medical, and we've got the knowledge from epidemiology, from medical ethics, and some of our mental health expertise. Mental health expertise used in tertiary prevention, epidemiology used, as we talked yesterday, about looking at the effects of war in the Democratic Republic of Congo, as well as in Iraq. We've got the skills in terms of teaching, in terms of helping strengthen community. We might have diplomacy skills or may not. And we've got the values that include many of the things I mentioned in terms of altruism, solidarity. And so that's the very simple model at different stages. So just wanted to give you a sense of the things that we can do as health practitioners, and maybe after Marshall talks about the things where we can go wrong, and then we can talk a bit more about this, and I could also give you some more concrete examples if you'd like. So thank you.
Thank you.